Good afternoon, everyone. My name is Linda Protopapis. I'm the Executive Vice President of Sales for Health Recon Connect. Welcome today to our webinar, Garbage In and Garbage Out, Controlling for Poor Data Integrity. With us, I do have two very special guests, Gregory Stein, who is the founder and CEO of Shadowbox, and William Baus, who is the Director of Laboratory Services for HRC, as well as the owner of Lab Revenue Navigator. For this webinar, please be interactive. Feel free to ask any questions via the chat or raise your hand. We will definitely call on you when you do have a question. At the end of the webinar, again, if you have any questions whatsoever, please let us know. We want to make sure that all of your questions have been fielded. Within a week, we will also be sending you out the slide deck as well as the video of the webinar. And with that, thank you again for joining, William and Greg. We can start now.
All right. Well, Linda, thank you so much for that very kind introduction. William, thanks for doing this with me. I always find it helpful when you start one of these conversations to provide just a little additional color and background to really validate that what we're going to talk about is within our area of expertise and it's worth the time for all these people to listen to our webinar. So maybe, William, spend another minute or so to really tie together your background and what we're talking about today.
Well, I think the relevant background I have that really provides me the insight on why I like the offering, the technology that Shadowbox represents, is the fact that I had been a revenue cycle director internally at a number of labs in my career. And so it gave me a ringside seat to what it's like to try to get information out of the referring physicians and all of the complexities and issues that accrue in trying to just get it to begin with and get it on time and get your samples out the door, but then get it correct or go back and talk to them. And what Shadowbox can do to resolve those issues is really highlighted by that kind of experience.
Excellent. Well, and for my part, so I was an executive at a large independent diagnostic lab, and we had billing in-house at times. We had third-party billing at times. We had really good partners, but we also were challenged day in and day out with exactly the topic we're talking about today. And part of my job was to try and find solutions to really increase efficiency. And we did all kinds of things. I even had at one point a prototype card reader that was in a clinician's office so that we could actually swipe a copay or deductible from the patient at the time of order. That failed miserably, by the way. But what has led me to is this whole concept of, and what we're going to talk about today is really getting the best possible data at the very beginning of the process, because it's so important from the start all the way through the finish. So let's jump into the overall agenda and we'll talk about sort of the flow of things so you know what's going to happen. Actually, before I do that, here's the learning objectives. I'm not going to read this slide. There's a lot of words here, but the bottom line is that wherever you are within your organization, we want you to come away with actionable information that you can use either in your day-to-day, you can use to sell up the chain in terms of improvements, or if you're a leader within your organization, start to think about and implement and really work on improving the entire process to improve clinical outcomes as well as your financial outcomes. And we're going to talk about Shadowbox, and we're going to talk about HRC and whether you're a customer, a partner of ours or not, we're obviously very proud and excited about the work we do. But regardless, the information we're going to provide today, we hope you will take away and actually implement regardless of whether or not you're actually using either of our services. All right, let's jump over to the agenda.
Excellent.
All right, so we've already done the introductions and overview. I'm going to start talking about the impact of poor data. And why is that important? It's important because if we don't really understand the problem we're dealing with, and I have talked to hundreds of executives across laboratories, imaging, remote patient monitoring, et cetera, wherever there is a need to access information that lives in an electronic health record to get it into your system. And it surprised me how little folks understood the impact of the decisions they were making as they were getting started. They were maybe taking a shortcut to get up and running, but then those processes just lived on like zombies. Then hand it over to William. William's going to really talk about the key areas of data control. What I mean by that is, what does it take to file a claim? What is clean claim? What are the data elements that are necessary? And then we'll talk through some of those things there. And once you have that basis of information, we're going to start talking about various solutions that are out there today, Shadowbox, HRC, and others, to really think through the various things that are out there. And from that, we're going to jump into a conversation about, okay, now you have all this information, you have an idea about various ways you can address it. How do I, in my organization, in my lab, in my imaging center, how do I actually go put together the information I need and then work through to actually see it occur? And as Linda said, although it says Q&A here at the very end, we will do our best to leave time for Q&A at the very end, but don't wait for that. If you have a question that comes up between now and then, put it in the chat. Linda will not interrupt us. She'll find an opportunity where we take a breath, which is very unusual when William and I talk, to throw out there, hey, answer this question. There's something coming from the audience. So let's jump into it. Let's talk about the impact of poor data integrity. All right, let's go to the next one. All right, I'm not going to read this slide. Most of this is really understandable and is intuitive, but I really like to think through and really point out a couple of the things here. If you are receiving handwritten orders or from tear sheets or printed rec forms, or you are getting faxes coming in, that results in a significant delay in process. Just number one, that's a delay. And then it leads to errors. And those errors can be multifold. They could be that you are entering in at the accessioning process in a lab the wrong test request from what was actually being ordered. So now you're not even answering the question that the clinician is asking you to answer. Or maybe there's not enough or inappropriate or inaccurate clinical data going in. And so even if you have information accurately transposed from the rec form into the accessioning process, maybe it's a toxicology report, but you have not the medication list. Well, you're going to report back something that's completely useless to the practice if you don't actually have all the clinical data. And then the worst part of all is that you could, as an organization, if you don't have the right information at the front end, you might send something back that actually drives treatment decisions in the wrong direction, and there could be real danger to patients. And ultimately, we're all in this for the purpose of supporting patient care. And then this is something that need not be said. You wouldn't be in business if you don't get paid. And often some of the data that comes through on that front end is missing, and it requires a whole process. And then we're going to talk a lot about that in order to finally file that claim and actually get paid. But don't take my word for it. Let's actually show you some stats on this. Go on the next slide if we could. All right. So recent testimony in front of the U.S. Senate Budget Committee by a Harvard professor suggests that there is a $950 billion expense every year on healthcare administration. By the way, he also says that's 3 times what we spend on cancer care. So would you rather spend a scarce healthcare dollar on clicking a button or filing a report, or would you rather prefer to spend that money on actually curing cancer? Obviously, the question is curing, or the answer is curing question. And in that same report, he said that 32% of that $950 billion is directly related to financial, clinical, and support functions. That's all of us and all that we do. And then the third point in that is that RCM automation, prior authorization automation, workflow automation are the biggest opportunities within healthcare today that we can implement to be able to reduce those numbers. Let's jump into the next section. William, on to you.
All right. We're doing good on time. All right. So the first thing is, okay, what's a clean claim? And I find this to be interesting. So you can read this, and Greg and I were talking about this yesterday. You can read that definition and still not walk away with a clear understanding of exactly what is a clean claim. But in general, the concept of a clean claim gets utilized by the insurance companies who have a financial objective of not paying the claim to disqualify the claim. If there's any element on the claim that is incorrect or not complete or inaccurate, well, then they can just deny your claim. And it's one of the very first types of edits that they'll go through as they look at some very basic things. And you've probably experienced some of these problems, and there are solutions for that embedded in Shadowbox. But let's just take a quick look and we can kind of talk about some of them. Greg, go ahead. What were you
I was
gonna
just going to say that I didn't mention this in the beginning, but I began my career as a staffer on Capitol Hill. And so I helped write laws and read regulations. And I can tell you that I don't know what that statement means that you just showed on that other slide.
Love it. Can you see that well enough, Greg?
I can.
Awesome. I'm going to assume that everybody else can then too. Okay, so here's your basic claim form when we're billing Part B claims, which most of us in the laboratory will be doing that. We would have a slightly different claim form, but the concepts will apply if you were billing, as a hospital laboratory on a UB. Yeah, we used to call these HICFAs, but now they're CMS 1500s, but it remained a 1500. So when you ever hear the word 1500 and people are talking about 1500s, this is what they're talking about. So what you see over here on the left side is, well, obviously it's patient information. So, right here is where you can have problems. Okay, so what's on the insurance card and what's on their driver's license card sometimes don't match, right? And you'll see a little joke I have written up on the screen here later, but you can actually have an argument about what the right name for the patient is, right? So somebody might know me as Billy in the office, but my insurance company knows me as William. You put Billy down, it's not going to be the right one, right? So you got to make sure you have the right patient information over here, and then you have insurance information over here, and presuming that they've already entered the data in their EMR, well, Shadowbox is just going to suck it right out. And of course they have. And when the last thing any doctor wants to be doing is retyping into a separate portal that they have to remember a login for somebody else's name again, right? And when they do that, they'll fat finger it or put the wrong name in, or they don't know, well, I know we call him Billy, but his real name's William, and they don't, they put in the wrong stuff, right? So, right there, you're going to cut out a whole bunch of adoption issues. And the biggest thing really I'm trying to address here in the claim form is data that gets fat fingered and data that you need on a claim form for it to get paid in order, and it can come across automatically and they don't miss information. So obviously everybody knows we need patient information. Obviously everybody knows we need insurance information. But we need the right member ID and we need the right insurance information. But, let's say you're working with somebody that did workers' comp, right? It's going to know that we're dealing with a workers' comp, and it's going to pull over accident information or whether it was an auto accident and maybe the date of injury and things like that, right? We need all of that information in there. Then once we get to the bottom half of the claim, we start getting into some other very, very important information for the claim to get paid. Down here is where you see this as CPT HICS, but that's where your CPT code goes. That's the 5-digit numerical code that you put in that says, hey, this is what I did, and this is what I want to get paid for it. And that's where your fee schedules are all associated to it. But the thing that gets that paid is having the right diagnostic code. If a payer is going to deny you automatically for something that's actually material to the claim and not something silly like you got the wrong date of birth or you didn't have the right, assignment of benefits, or you didn't have the right, date of birth for a patient on there, which are silly mistakes to make. There's really material medical necessity ones about whether they do or don't pay for that service, or there's a benefit for that service you provided. It's going to accrue related to this diagnostic code relationship to your CPT codes. Now, of course, Shadowbox and Health Recon and any billing company should never be, and any laboratory should not be putting down diagnostic codes just to make the claim get paid. That's called fraud. That's called practicing medicine without a license, and you get into big trouble for that. So we're not talking about that. But there is the capability and the potential to support you with Shadowbox on being able to present diagnostic codes that are publicly available, that are for reference, because of course it is always the responsibility of the treating clinician to diagnose the patient and treat the patient based on those diagnoses. But sometimes it helps that there's a reference, or maybe they've forgotten to update it. So having that be able to be there to sort that out is a true game changer. And we'll talk a little bit more about that, and specifically around PGX if we get to the bottom slides here, because I don't want to take up too much time on just this slide. But
let me make a quick comment here,
yeah.
William. And so every time, I'm sure all of you have been to a doctor's office, and what is the first thing that they ask you to do when you walk into the doctor's office? Confirm, update, edit your demographic and insurance information. And they do that because the doctor's office wants to get paid for the services they're rendering. And so when you're accessing the data in the EHR at the time of the order, the day the patient has come in for their other services, you're getting data at the best possible time versus getting it after the fact from a clearinghouse, which could be weeks, months, and even longer out of date. And this is especially important at the early part of the year when employers are changing their plans and people are changing their plans. And so there's a lot of discrepancy between what might come across from a clearinghouse versus what's coming across from what's in the EHR at the time of work.
Fantastic. And, you know, getting physician signatures and all of this sort of thing, that also is really greatly enhanced by using Shadowbox, and very important things for us to have. So, yeah, I've run into these problems more than once, multiple times, about, you know, literally something similar to this, right? You know, the health insurance company doesn't think you know your name, right? Or you don't know the name of the patient. It's just a different name, or they have the wrong date of birth, and trying to figure that out can be problematic for billers. So it's correct payer information, correct patient insurance information, correct diagnosis information. These are things that are going to cause your claims to get denied. And I wouldn't be surprised if you wouldn't run into about 25% of claim rejection denials, this type of level of thing, being related to you having bad payer information or bad insurance information. Whether that was because it was fat fingered or it was put in incorrectly. So you can also integrate in with eligibility verification tools with Shadowbox to help you do that. And it being able to do that in time and have enough time to get it done before you process the sample, which I'll kind of show a little bit of a little workflow kind of idea about this, is super important. And you don't have the ability to do that in time unless you're getting the order to happen online. And the way you get the order to happen online is by not forcing them to use your portal, because they got 50 different portals. It's to use their own that they're already using, where their data is already existing, and they have to do as little bit of work as they need to do to get that test ordered. That's what the people that run that office want to do. They're real busy. They don't have time to redo all this stuff. And so one of the other things you might run into at times is a referring physician, as opposed to a laboratory, never has a problem being credentialed with a Medicaid, right? If a provider wants to be in with an MCO, a managed care organization, or the state-based Medicaid, all they got to do is ask, and they're going to get it. And that's not the same for us in labs. Most of you are probably familiar with this, or if not, get ready, buckle up, because it's going to happen. And so you'll go and talk to a referring physician office, and they're like, oh yeah, 40% of our business is Texas Medicaid. Well, I'm here to tell you, no, 40% of their business is not Texas Medicaid. It's Medicaid under Texas, but it's an MCO 80% of the time. So, you know, it's Superior, Ambet, or what have you, right? And so they might just call it Texas Medicaid. But by the time you get it and you try to submit it, it's going to be something else. So you need to do that eligibility verification check, whether your billing company helps you do that or you take control of the bull by the horns at the lab. You got to know what your right payer is, or, you know, you tell the billing company, by the time they figured it out, you've already run that sample, and you've got no chance to ask for a self-pay or perhaps send it to another laboratory who is credentialed so that you can take care of that sample. But you'll have problems with getting the right payer information or the right plan type, and then you're not credentialed with that plan type. And so taking care of that and getting that information early, this is key. You know, and then the correct patient information as the insurance knows it, and the right date of birth as the insurance knows it, is really going to help you to get that claim to go through the clearinghouse and get accepted by the payer. And then we did touch base on the diagnostic code, so I'll just keep moving on. We're keeping on. So back to garbage in, garbage out. You know, what are the practices leading to unclean claims, right? Well, it's going to be about us not checking the eligibility, or us getting information that's inaccurate, or getting fat-fingered information from people. So, you know, you just can't figure out what the right date of birth is, or what the first name last name first, all this kind of crazy stuff. It's all eliminated by, you know, cleaning that up and having it straight out of their system. And then there's another element here of, you know, being a proactive, supportive partner to those clinics. If you have taken the time, because you have the time, because the order has come in now a day ahead of you receiving the sample, because they ordered through Shadowbox online in their native system, now you've got a head start on this information. You can check the eligibility verification. You can get that done through the billing company or through yourself. And now that you've identified, oh, wait a minute, this isn't the right information you've got in your system. You've got a bad member ID here. It's expired. Here's the new one. Now, when you make that call to ask for that information, which is usually treated as a disturbance to those in the office, well, now you could say to them, hey, by the way, I just wanted to let you know, patient JC Jones, right? You had her member ID wrong, and here's the right member ID. Here you go, right? And now when you're asking them, when you're calling, they want to answer the phone because maybe you're there to help them and not just be a burden on them. So you can't do those things if you're not applying this technology. This is the right way to do business, right? Be a benefit to your partners instead of a burden. All right, and then medical necessity, you know, having those good ICD-10s. And again, we've given our disclaimer. Nobody is telling anybody that they have to use an ICD-10, but it is helpful. Like, here's a good context scenario in PGX. So, you know, a lot of people are doing the psych panels now, which are covered by Medicare and some other payers. We've got to talk about that if you want to know more. But if you want to get paid for that, you're going to need the right diagnostic code with a lot of the payers, particularly Novitas and First Coast. And so if you wanted to do a tricyclic or an SSRI, you're going to need an F code diagnostic code. And what's interesting is it's not all of them. And so sometimes somebody might be doing an initial evaluation of a patient, and they've only updated that diagnostic code during that initial evaluation, yet they've continued to provide medications for which they have a very valid reason for ordering a PGX test, but they haven't updated the ICD-10, and you're one digit off. Well, it would be nice if you could kind of show them a background of, hey, these are what require medical necessity, and they could go, oh yeah, my initial F code diagnostic code hasn't been updated to what they currently are, which fits in alignment with why I'm giving them this drug that I now want to get a test on to make sure I can change the dosage or update the dosage or maybe look for a replacement drug, right? Again, you can't do that if you don't have a system where you've got control over how you're going to organize that data for your clients.
Forward on, I want to comment on that because payer policy isn't static. Payer policy is changing all the time across the board, and it's not just about PGX. It's really any test modality that is out there, and that is, what are the various requirements that determine that that test is medically necessary? Is it being signed by a clinician or a legal designee at the time of order? It's not just a pad where they pre-signed a bunch of signatures and then filled out later by whomever it might be. Are the ask it order entry questions tied into the ICD-10 codes that demonstrate that medical necessity? So you think about a UTI, for example, the traditional path is you do a culture and the culture comes back and you have a UTI, or maybe the culture fails and you need to reflex to a PCR. Well, just doing that reflex to a PCR to determine the actual infection type isn't good enough for most payers. Is there that you actually have to report there was a failed culture? You have to report whether or not there was a fever at the time of order. You have to report whether or not it's recurring UTI. All of these ask it order entry questions tie into ICD-10s, which tie into the claim form that William showed you, which tie into getting paid on the first pass. So back to you, William.
Yeah, and I've got a little workflow that is kind of, I'll start out with this sometimes when I'm working with a client to help them make that decision about, hey, do I want my billing company to try to support me on doing the eligibility check before I run the sample, or do I want to take that over by myself? But one thing is key. You can't eat samples and survive as a lab for very long. And what I mean by eat samples is you can't be running samples that you should have known already that you're not going to get paid for. And then the only way to do that is if you've got, an online order before that sample actually shows up, you can check that eligibility to make sure that, well, they said it was Texas Medicaid, but it's not really Texas Medicaid. It's actually Superior. And oh, guess what? You're not credentialed with Superior. And then, okay, let's take a look at what's the sample type. Well, does Superior pay for PGX? Oh, they do? Okay. Well, I could send that to LabCorp or Quest or maybe another partner lab who's going to give me the result back. And then I can put that result in my system and I've taken care of my client, but I've not experienced the cost of running the sample. Or maybe it is Superior and Superior doesn't pay for PGX. Well, then maybe I'm going to pick up the phone and I'm going to call the patient and say, do you want to do cash pay price for this? Here's my cash pay, take the money. Then you say, go ahead and run the sample. But what we've got to stop doing as a lab is taking it on the nose just because a payer doesn't want to pay for something and they've got bizarre, rules. Now, also, we're well aware of how to use the biomarker laws to get you paid for commercials. So there's about 15 states that commercials that say they don't want to pay for PGX, they will now. But you've got to do good appeal work, and that kind of falls back on your billing company, right? All right, so back over to you.
All right, so let's jump into some of the solutions. The very first, most important, absolute, incredibly first step is to take your fax machine, unplug it, and throw it out the window. And then don't ever let an order come in from any clinician on a fax. And I mean paper fax off a rec form or even an e-fax. Here are some stats. I forgot to put in the reference, but I could source it for you at some point. But here are some facts. Facts about faxes. And that is that 1 out of 4 of them are incomplete, and you have no ability to determine if it's coming in on paper or fax. How to, hey, clinic, I'm calling you because it's incomplete. Or number 1 out of 5, number 2 there, 20% of the time, you're actually having to call the practice back. And they hate that. They absolutely hate that. They have a very busy job just dealing with their own situations. You get labs and imaging centers, everybody calling them all day long, interrupting their day. That is a frustrating thing and is a concern in terms of keeping those customers happy and continuing to order from you. And then, the others, the 10% don't even have the clinical data. All of these things are extremely challenging related to the fax machine. And I'll just say, as a story, I was on a ride along with a rep, and we had we stopped at this practice, and he said, oh, I've got the new recs that just got printed. And he opens up his trunk, and there are thousands of rec forms in every way, shape, and form, and some are crumpled up. He spilled his, Diet Coke on one of them. And so he goes into the practice and drops a stack of, 500 of these brand new rec forms that cost like $3 each to print. And he takes a stack of 500 unused rec forms out and throws them in his trunk. I am not sure he actually substituted the new rec forms for the old rec forms. And so just understand that labs, especially today, are constantly changing their test compendiums. They're constantly changing ask and order entry questions. They're constantly updating to be compliant with the rules and regulations. Go for it, William. I'll turn it over to you.
We didn't say that yesterday when we were talking, and that's a huge thing I run into all the time. And by the way, so the OIG has a compliance plan for laboratories, right? Now, you're not required by law to do one, but it's a different story. If you don't have a compliance plan, this is my little plug for everybody should be doing compliance, right? But here's the thing. If you don't have a compliance plan and you screw up, then you had a plan. Failure to plan is planning to fail kind of a thing. That's how the OIG looks at that. You were okay with doing things wrong is how they look at that. Now you have a plan, but you didn't follow it. Well, that's way better. And you're instantly out of the fraud category for that, right? You showed that you wanted to do it right, but you screwed up and you made a mistake. Well, this is one of those screw ups that you make a mistake of all the time. This is going on. I see this. There's not many labs I couldn't go into, and I'll bet you that the rec that the order is coming in on is not exactly what they're running. And guess what your billing company is doing? Your billing company is billing off of what you told them you're running, and they're not looking at a rec if you're integrated. And so you're billing the wrong stuff as opposed to, so ordered, resulted, billed should match. And if those things aren't matching, you're screwing up and you're billing incorrect things, and it's an honest mistake. But you don't have a compliance plan talking about this is how you do stuff, and you have one of those mistakes. Well, now it looks like maybe that was fraud because maybe you made some extra money doing that, right? Yeah, that's a key element, key point right there. Yeah.
Yes, that's so important. And I think that we've covered this slide. So let me just actually talk about proactive solutions, alternatives to the facts. So number one here is electronic integration. And this has been around in various forms for a very long time. And so we're talking about somebody at the EHR writing code with somebody at the lab or some intermediary, and it works. There are hundreds of thousands, millions, maybe even billions of transactions that go across on HL7s back and forth. And but they're time consuming to set up. They are often very costly. They require a conversation between two organizations that on the EHR side, they've got 1,000 labs out there that all want to integrate, and they don't have the bandwidth to actually solve these requests in a very timely fashion. And nor do they really care if it is solved effectively on the first try, because they're just moving on to the next one. And I don't mean to demean them in any way. I mean that every time that an EHR picks up the phone on their service line to do an integration, they're losing money. The second part about it is, even though that they have now moved to things like application program interface or API integrations, which is an easier and more stable and a better opportunity for integrating with those EHRs, several concerns occur that are across the board of the traditional integrations. Number one is the information that is available through an HL7 or an API is dictated by the EHR. It may not have all the information that you need in order to actually provide a good clinical result or get a claim paid. The second thing is that even if it does have all that information, the EHR vendor is not going to set up a very specific and clean lab specific ordering process. They have a generic ordering process because they have, like I said, thousands of labs and other providers that are trying to order through a single point of entry. And so when you have either an API ordering for a process or an HL7 through the EHR itself, you are at the mercy of the EHR vendor in terms of the ordering process, which can be complete, complex, could be incomplete, and so on. So that's why labs started building web portals, and other vendors, a lot of LIMS vendors offer their version of a web portal. And you said it early on, William, about provider's point of view. I have 17 different portals I'm going to log into. No, that's not going to happen. And so the challenge with the web portals is, how do you get utilization of it? And even when you get utilization of it, and there's this beautiful lab specific experience that you've invested in with the lab I worked at, we did, it was awesome. It was an amazing WalkMe's, payer policies, utilization alerts, I mean, everything. But you're still getting keystroke error. You're still getting utilization challenge. You're still getting individuals who are very busy at the practice who don't want to go screen by screen by screen. And so the swivel chairing between the web portals, better than perhaps an electronic integration in terms of cost, but not necessarily better in terms of the data you're receiving. And that's why and what leads us to, or led me to founding Shadowbox. And that is, how do you take the information in the EHR at the time of order and accurately and discreetly transcribe that securely and compliantly into an ordering process, whether it's a portal that just populates the portal, or whether it's a digitized order form that kind of looks a little bit like that 1500 you showed, but is tailored specifically for that lab. How do you do that effectively so that all the clinic has to do is validate that what transferred by looking at it, it's visual, and then they select the test they want. They answer the ask at order entry questions that are tailored by the lab to that compendium to demonstrate medical necessity. And when they click submit, it validates that every field that's required is actually filled. And so you don't get an incomplete order. You're getting good, clean, complete data at the very front. And that's really just the beginning, because as William mentioned in his flow chart, there are a lot of downstream functions that labs and other ancillary service providers engage in to try and enhance their ability to get paid. And so if you at the time of order can run an eligibility check based upon the insurance that comes across and verify, it's going to be better in the EHR, but we find that even the stuff in the EHR isn't accurate all the time. Run that eligibility check. if it's not eligible, do a discovery, pull out the right information if it can be found. Once you have all of that information, you can now send this information off to a prior authorization vendor before the specimen is ever submitted. So now you've got CPTs, you've got ICD-10s, you've got payer information, you send it to the prior auth vendor, and if it's an auto auth, you'll get the auth code back, append it to the order, and it goes in the front door. And even if you don't get the auth code back, because it's a manual process of some sort and it requires work by the prior auth vendor, you're able to kick it off so that you can actually date and timestamp that the authorization process was started prior to the delivery of services. And often, William, you could validate this, often you'll get denial of claims because the authorization process started after services were rendered. There are also number 5 here is, okay, now you've got good, clean information that's coming in on the front end. You've got your eligibility discovery, your prior auth. Shadowbox can even work with vendors to send a patient fee estimate or a link so they can click to pay the copay deductible at the time of order. Super helpful if it's if it's a test that they're very anxious to hear the result from. You do a cancer test, they're going to want to pay their copay or deductible. If it comes back negative, now you're chasing them after the fact. Oh, do I really need to pay? I don't have cancer. So number 5, though, is now all that process occurred. You've received the specimen, you've given a good clean clinical report back, and it's in the RCM process. Which claim do you start working first? And we all have limited resources. We all want to minimize our costs with our billing companies or our billing staff internally. So there are automated processes that can be set up that are rules-based that will help your RCM team, or if you can support Health Recon Connect's RCM team, that says, get next. And it will pull up the next claim that is in the queue that will have the highest return on your investment of time and FTE time. Super important to do, because you don't want to spend an hour filing an appeal on a claim for a lab test that's going to pay you 20 bucks. You're losing money every time you touch it. So these are the types of automation solutions that are out there. And I'm going to say something that I think is really important for everybody to understand. There is no silver bullet. There is no absolutely one size fits all, everything works for everybody. You've got different workflows and practices. You have different types of practices. You have different types of labs and modalities and all this. It is really important that when you think about automation, you think about a tool belt or Batman's utility belt, and you pull out the tool you need for the use case that you're experiencing. And I think all of these solutions can be plugged into a process that maximizes your experience with your customers and maximizes your return on the back end. All right, William, I think I beat that one to death. Any questions in the audience, or you have any thoughts on that?
Yeah, no, everything you're saying is right on the money. I mean, I see a really good opportunity for pharmacogenomic testing right now. I think people are starting to get on board with that. I've noticed, well, of course, we've always had Medicare follow in CPIC guidelines and the FDA guidelines, and that gives us about 190 potential gene drug payable combinations. And in general, though, commercially speaking and Medicaid speaking, they're still kind of behind the times. And so you might have maybe it's not that there's not anybody that doesn't pay something for PGX, but what they do pay for are very esoteric, like tetrabenazine when you've got or oligostat when you've got Huntington's or Gaucher's disease. Not many people have that, right? And so if we can utilize, a tool like Shadowbox that can help people understand that we need the right diagnostic codes, we're going to be able to get paid for Medicare. And it's opening up, not only because we've got about 15 states with biomarker laws that basically reference and say, hey, you should, if there's an LCD, then you state, whatever state we're talking about, you should be paying for this, right? You can't tell me it's experimental investigational. And then, and we're starting to see, I think all the anthems just adopted Carillon's policy, which is very similar to Medicare's CPIC level type policy. So we're going to see a lot more people, I think, looking at PGX, adopting the payment of PGX. So if you're doing PGX, Shadowbox will be able to help you with that in the scenario of being able to provide you with, again, support on that diagnostic code level, support on the med list. I mean, it's pulling over the entire med list, right? And then we can make sure that it's pulling over the med list that relates to what's a payable gene, right? And that enhances the order. I can't tell you how difficult it is to get somebody just to order the darn thing right. I mean, I would, you know, and I'm going out a little bit on a limb here, right? But this, what I'm about to say is solid knowledge, okay? People that are doing PGX in Novitas or First Coast in a non-MolDX MAC, therefore they don't need a Z code and technical assessment, but they do have this extra added requirement of a specific diagnostic code for a specific gene. And because of that, the ordering process is complicated. And because of that, you're going to average out to about $500, right? Whereas if somebody's in a MolDX MAC who doesn't have a diagnostic code issue and can bill a panel code for a lot of reasons that are more complicated than we have time to get into here, they're going to average out to around $900 very easily with less ordering requirement problems. So if you want to be in, but you actually have a chance to get a much higher reimbursement than that, because with Novitas and First Coast, you're going to be billing in a MAC that's going to, well, if you're working with a provider that's doing something polypharmacy with, you know, managing the meds for lots of meds, you know, like more than say 5 meds, you're going to be in the $1,000, $1,200, maybe $1,800 range if you're going across, you know, psych and cardio, and there's several different cardio meds that hit several different genes, by the way, right? You know, hypercoagulability, anticoagulability, all that kind of stuff. You know, having this be getting done during this ordering process, getting the right diagnostic codes, getting the right meds, it's their ROI is there. I mean, and I would love to work with anybody on trying to look at with Shadowbox. Call us. Let's do a little deep dive with you. I think we could show you, hey, this is what you're not getting paid for. It's because of diagnostic codes. This thing will help you do that. No-brainer type of a scenario if you're looking at PGX. It also works on other things, but this is the one that's coming to mind right now, right?
Yeah, William, it's a really good point, and I'll just add a plug here as another feature of the utilization of Shadowbox as a technology, and that is that if you're doing traditional integrations or APIs, they are different for every single EHR and often every single clinic using an EHR. And so if you change something in your compendium, or there's a new LCD that came out, or there's a new requirement from a payer for a specific type of medical necessity note, you have to do it over and over and over and over again across all these EHRs with all these various vendors, and it's extremely time-consuming and expensive. Or you could update it on your web portal one time, and that's a value. Or you could update it with Shadowbox one time, and now every time that the order is being requested from a clinic using one of those technologies, it's already updated and it's a one and done. And that's incredibly important for reducing that cost of maintenance, reducing that FTE time, and still getting the best possible compliance with the payer policies.
Absolutely, man. Absolutely. All right.
This is you, William.
Linda. Well, or what you want me to go for, Linda?
Sure. Go right ahead, William.
Sure. All right, so Health Recon hosting the webinar today. So we can all read this. Health Recon does a lot of focus on laboratory billing. The predominance of our clients are there in lab. And we have extensive, massive experience. We're born out of the experience of dealing with labs. And so, you know, when I talk to clients in my Lab Revenue Navigator hat, I will explain to them, you need to look for a biller that understands laboratory. I mean, if you're going to deal with somebody who's done only provider-based billing, it's not a good fit for you. And the reason is a provider has completely different scenarios. Like, just to give you one example, any provider wants to get in network with anybody they can. Now, I'm not saying that they're going to get like the best rate negotiated by themselves, right? Maybe they join an IPA or something, they got negotiation power. Well, with a lab, you're not even never talking about negotiating. What you're talking about is, will they even let you in or not? They don't want you. They don't need you. They've got LabCorp requests. And so, you know, if you don't know that, right, then you're going to spin your wheels, or you're going to be talking to a biller like, oh, let's go get me credentialed. And they need to be able to tell you things like, yeah, you're going to get your state-based Medicaid, but it's going to be, 80% of the time they're not even going to be on that. And, it's going to take you 50 years if you're in the same state, maybe to get in with those other ones. Good luck trying to do that for 100 labs. So just the orientation, understanding fact that if you've got a referring physician that's going to be working with your lab and they're going to be trying to send you a bunch of Medicaid stuff, probably not a good client for you unless you've got other plans in place, like we already discussed about getting those samples to go to someone else and having enough time to get that done, right? Well, those kind of things all sprinkled throughout the entire revenue cycle relationship with somebody like Health Recon is going to help you out. They're going to know, hey, do payers kind of pay for this thing or not? Like, here's another good example. If you're dealing with somebody who predominantly didn't do lab billing, right? They're probably not aware of the state that you're in, that you're required to have a Z code and what a Z code is and how it works, and that you're not going to get paid from Medicare for nail wound or UTI, for example, if you're in Michigan, right? And you got somebody that's not familiar with Michigan, not familiar with labs, they're going to go through a big learning cycle just to figure out that you're not going to get paid and there's nothing they can do about it, right? And so, what are your strategies for, overcoming that? And so Health Recon's put a lot of investment in AI that really, from your perspective as a lab, do you care about AI? Well, I mean, it's cool that we're doing it. We're upset. I'm not upset. We're on top of it, right? And we're using the latest technologies out there, which is an important thing. But what it means to you is we get the work done faster and we don't have as many people touching it. So again, doing things with software helps you out with not making keystroke errors, not introducing human error into the process, right? And then, of course, there's analytic dashboards for you to take a look through and help you understand. So you've got a window into everything that's happening, and you can see the work occurring and use that to ask your questions about how the status of your billing is going. And then we have a concierge service model, which you get a dedicated account manager, and you'll meet with them weekly. And they review with you what the status of, bills going out, payments coming in, what expectations you have for additional income next week, credentialing issues, whatever it is that gets discussed. And, you can pick up the phone and call them. They're US based, and they basically advocate for your account and treat it like it was their own money. And of course, you got the statistics down there, which, just shows you that they're good at what they do, and everybody is happy with the services provided by Health Recon.
William, let me say something in addition to that. First of all, I was absolutely thrilled. My whole team was when your team invited us to participate in this webinar, and we not only because of everything you just said, but it matches. But what's equally important is, like at Shadowbox, we have a no jerk policy. We fire clients if they don't treat us well. We just don't have time in our day. We don't want to work with those who don't treat us well, who don't respect the work we do, who don't believe, who give us a hard time for things that are, what have you. And I have absolutely enjoyed, and everyone I have met at Health Recon Connect has been actually a pleasure to work with. If you're watching this webinar right now, you see we're real people. We joke around, we have fun. We're very serious about what we do, of course, but it's at the end of the day, it's always a conversation between people. And that's one of the things that I've really enjoyed about this relationship with Health Recon Connect, and so why you're one of our most important partners.
Well, a lot of it has to do, Greg, I think you lived the pain that you developed a business around to solve, right? And that's the same for me. I was inside the lab. I've had these problems, and that's what gives me the passion I have for it, because I like being able to provide solutions, to know what I'm talking about, be useful, be of use, right? I have a passion for that. It's not necessarily that I like numbers or anything, or I like figuring out the crazy crap payers come up with for why they're going to pay for something or don't. That's not my passion. My passion is helping somebody understand what the game is and how to play it, right? I mean, that's where it's fun for me, watching somebody not step off the edge of that cliff and keep climbing that mountain and make it, right? Where so many others have, fallen by. I mean, it's like literally, I think I should make some kind of a little post about that. Like the people they see on Mount Everest that are frozen, like going up the mountain, nobody carries them down or anything. It'd be like that. It's like, see, that would have been you, right? If you hadn't stepped here, right? Yeah. Or if we hadn't decided to go back because the weather's too bad, right? Or, like that kind of stuff. But
That's
awesome.
All right, so we got just a few minutes left. Let's jump into how do we turn this into some actionable items for our participants today. And I'm not going to read all the bullets, but I will just say sort of start with the facts. As I think I mentioned at the beginning, I have talked to hundreds of labs and imaging centers and others, ancillary service providers who don't actively track their costs, don't actively track their workflows. And sometimes that's simply because they're growing so fast. They just don't have the staff, the resources, the time to even think about it. There you have it. But
that's what LRN will do for you. It's not a billing thing. It's not a shadow box thing, but it's hey, you need somebody to come in and help you do it. But yeah, come on.
Let's start. But if you can start with the facts, you can start to understand where your pain points are. And I'll give you one quick story. At the lab I worked at, we actually put pedometers on staff in the lab just to find out how much they're wandering around every day doing their jobs. And it was an insane amount of distance. I don't remember exactly. It was somewhere between 3 and 5 miles they were walking inside the lab every day. So we used that to be able to reconfigure our lab so that they didn't have to walk around all day. Just a pure efficiency thing, but also a healthy thing. Like, you want to make sure that you're taking care of your people. But anyways, understanding what those facts are as a start is really important. And you can see this on here, and we'll provide the slides for you for further review. But once you do that, then you need to take a look at what are the systems you currently have in place today. Okay, what's my list? What's my limbs? What's my my billing system? How do I do integrations? The things we're talking about today, but across the board, understand what those systems are and understand what their capabilities are. Because as I said in a slide or two before, there is no silver bullet with systems. You've got to be able to know what works, what doesn't work, what you'd love to have. And that's sort of number 3 here is now that you know the facts and your pain points, you now know your systems and what they can or can't do. And are they addressing those pain points? Now you can create a gap analysis. Oh, well, it's not addressing this pain point. And this pain point's costing me 10% of my bottom line. No kidding. That could possibly be an outcome. So if you go to the next slide, now that you have your gap analysis, now it's time to go to market. And whether you're an operator, a single contributor, a manager, or even in leadership, it's really important that you actually go to market and understand what's out there. Like they always say, if you're doing work on your house, get 3 quotes from 3 different plumbers or what have you, right? Because you need to know what the pricing is, you need to know what the services are, you need to know what their reputation is, and you need to do all of that work so that you can then do a reverse calculation as to, oh, if I invest in this change, sure, there's going to be some friction and disruption perhaps in moving from point A to point B, and this is how we've always done things. But if you have the data that shows how much you're spending, what your current systems can or can't do, what the market is providing that you can invest in to achieve an outcome that is better clinic satisfaction, faster turnaround time, fewer denied claims. These are all of the factors that you can then calculate. One of the most interesting things for me that I didn't even realize when we started Shadowbox is that with Shadowbox across all of your ordering clinics, you actually can, day before, actually staff your accessioning team to the level of specimens coming in the front door. Just as one example of how this kind of automation can help drive enterprise-wide improvements in efficiency and profitability. And then if you're not a decision maker, this is the kind of information you can present to the decision maker. If you are a decision maker, it's a lot easier to say, you know what, I'm going to do this. And the next part to understand is once a decision has been made to move forward, that it's a process. And I talked about a little bit of friction and we've always done things this way. Understand that no software, no automation is 100% plug and play. There's a lot of initial work that needs to be done to get these applications up and running. But once they're up and running, once they're tested, once they're in the field, you start to see just this incredible amount of a return on that investment in time. And equally importantly, in order to Go ahead, William. You want to say
I'm sorry for that interruption, but I just want to make sure you're talking about the initial setup of Shadowbox, but once you're out there in the field and you're like, hey, I've signed up an account, it's pretty much log into this new browser and it starts working.
Yeah, absolutely. It's a really nice clarification.
Yeah,
Whether
yeah.
you're using a billing software, whether you're using a eligibility or discovery software, whether you're using prior auth software, whether you're using Shadowbox software or a hub and spoke integrator software, it's the setup that initially causes the initial process. And we have gotten it down to a science here at Shadowbox. We can start from contract and getting the requirements done to going live in the field in 8 to 10 weeks. So we are the fastest in the industry in that setup, but it's important to understand that the lab has to be a partner in the process. And that's bullet number 2 at the end there, which is besides being an internal champion, you need to appoint and hold accountable everybody on your team for that setup process and hold your vendors accountable. And sometimes there are more than one vendors. And so, for example, in a typical Shadowbox situation, you have Shadowbox as a vendor and you have a LIMS as a vendor. Hold both of those vendors accountable to meeting the timelines and doing the work that's necessary. And equally important to all of that is once the train is moving down the track, don't change the scope. Get it live, get it done, get it tested in real life, IRL, in real life out in the field, so that then you can do, now I know what I need or don't need, because you don't really know that until you're actually out and using the solutions that are out there to determine what else you might want to change in the process. I realize that this piece sounds like a challenge, but if you've done all your homework on front end and you've got buy-in throughout your organization about making this investment, and now you've written a check to start making that investment, you've got to do what you can to make it as smooth as possible.
Q&A.
We left some time for Q&A. That's a, given how William and I often are riffing off each other, that's a surprise.
I love it.
So, Linda, do we have anything from the audience that you're aware of, or are we ready to?
We don't, not at the moment. Does anyone have any questions for Greg or for William that they can answer right now?
Candy, I know you got to have something.
And while people are thinking about that, I'll just say, if you don't have a question now, but you come up with one, you could reach either of us or our organizations through info @ and I think we actually may even have a final slide here that shows the websites and the email addresses. And if not, it's info@shadowbox.com and it's info @ that's for you. That's a cue. Sorry, we were riffing there. William, what's the?
I'm looking at who's on. I was looking at who's on the call. Sorry. Wait. What were you saying? Oh, here we go. Right there. Yeah. Sorry.
healthreconnect.com, info @ there's the phone number and the websites.
And Greg, I think we have a question for you from Sharath.
Oh, okay. Yeah. Hey, great question. So, go to shadowbox.com and take a look at that. But in short, Shadowbox is a browser application that wraps around an electronic health record system in the clinic's office. And what we've patented is the ability to access every data element within the EHR and extract it in a discrete fashion. And then using our secret sauce special feature functions, move that data into exactly where it has to go throughout an ordering process. We then validate that information is accurate, correct, and complete, and we convert it into either an HL7 or an API and send it off to the lab. And a one and done setup with Shadowbox on the back end enables you to connect to as many EHRs that are in our library and as many clinics with as many users as you want and as many transactions that you want with complete transparency as to what your process is going to be. And there's a follow-on with our last minute. What is Health Recon all about?
And Sharath, just to let you know, Health Recon is a full service RCM company, so we can help with all of your billing needs, or we can do things on a project basis. For example, AR cleanup, coding, credentialing. So you just let us know what you need assistance with and we can help you. Are there any other questions before we close out today? No additional questions, gentlemen. So thank you, everyone. Thank you to Greg and to William for being amazing speakers. And also thank you to all of our guests who have attended today's webinar. Again, we'll be sending via email the slide deck as well as the recording. If you have any questions, the contact information will be within the body of the email. And with that said, we'll have a close of our webinar today. Thank you, everyone, so much, and have a wonderful day.
Live long and prosper.
Thank you. Bye-bye.